This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us tonight Dr. Kostas Fountas. Welcome, Kostas.
Thank you, sir.
Well, it's good to have you with us. Now, tonight we can talk about several things. We might talk a little bit about your background. I mean, you've been with us before here, and you just how is life going for you?
First of all, I would like to express my gratitude for having me. It's really a great privilege and an honor for me to be with you tonight. And you know, I feel quite comfortable in Macon, Georgia. It's my, if not my home, it's my second home. I've spent several years here in the medical center, and I remember with nostalgia these years. It was a great experience, quite didactic for me. I had my basic neurosurgical training over here, and then I subspecialized in the management of epilepsy surgery and a subfield of neurosurgery, which is called functional neurosurgery. And then I moved back to my home country, to Greece, where I currently practice. I joined the University of Thessaly over there. Thessaly is the center of the Greek mainland, approximately 1.5 million people. And I established the first epilepsy surgery program over there.
Well, that's a good story. I mean, so we can talk about Greece, we can talk about functional neurosurgery, but you're in Larissa, is that correct?
That's correct, yeah. It's the capital city of the Thessaly, of the region of Thessaly. Actually, there are 4 prefectures over there, including Larissa, which is a town of approximately 250,000 people, and is located in the center of Thessaly, in the center of the Greek mainland, as I said, approximately 360 kilometers north of Athens, to have an idea about the geography of the area.
Now, if I'm not mistaken, which I could be, besides that being your native habitat, did Achilles come from Larissa?
You are absolutely right. You are absolutely right. And actually, there are another 2 well-known historical landmarks associated with Larissa. The first is Hippocrates' tomb.
Yes.
Actually, Hippocrates practiced medicine in Larissa, and then he was buried there. And also there is a very well-preserved ancient theater from the early Hellenistic era, and is located in the center of the city and is still functional. So it's quite impressive to see that. If you visit,
yes,
if you ever visit Larissa,
sure.
Please make sure that you'll see. It's one of the must-see sites.
Now, I take it Achilles did not make it home again. He did not come back. Is that correct?
That's correct. That's correct.
That's a good story. Well, in another thing,
although he was supposed to be immortal. You know?
Yeah. Oh, that's right. Yeah. So maybe he's on Mount Olympus. Which can you see Mount Olympus from your home in your
Actually,
town?
I can see it from my hometown. I see it every single morning,
yes.
And it's really reviving to see the slopes there, and it's a great picture.
Yes.
It's a very vibrant picture to see it every day.
Yes. Well, it's obvious Greece has a tremendous classical origins, all this great culture that exists there. There have been some problems, though, with, I guess, the economy and is there, I know things are rebounded somewhat. It's been a very difficult period of time. Is there any lesson you could, as you consider the Greek experience, anything to worry about in the U.S.?
I think many lessons can be learned from the Greek story, that Greek tragedy
yes.
that we are facing. I think that the crisis that Greece faced since 2009, 2008, is a really deep social crisis, not only isolated financial crisis. And I think that all these kind of political experiments that politicians attempted over there, tried to make, had a significant impact on the quality of life of people. people really struggle, and I think that affects every single aspect of social life. And I think that the aspects of life, of social life, that are greatly affected are mostly education and health.
Yes.
So this is a lesson, the first lesson that somebody can learn from that financial crisis in Greece, and I think that it's a worldwide lesson that it's not only a financial problem, it's a problem that affects every single aspect of the life, the daily life. In every possible way, somebody's life is going to be changed after a major financial crisis. So I think that somebody needs to be extremely careful about making any kind of experiments, and people always like to have as much benefits as they can.
Yes.
But on the other hand, they need to remember that further down the road, somebody needs to pay for all those benefits.
Yes.
So I'm not saying that socialized medicine is not good.
Yes.
Socialized education, as it is in Greece, is not good. But somebody needs to be extremely careful and very meticulous about planning very accurately all these things.
Yes, you know, we talk about a little bit, actually, not to overkill a very complicated issue, but I think one of the things that happened in Greece was the debt the country had was a very high debt there, and funding the debt became difficult, and it's a really complicated story, but it was the ratio of the national debt and the interest payments that were needed to the amount of money the economy could produce, and the politicians basically had created an enormous national debt, as I understand it. Is that a correct story?
I think that everybody is responsible. I'm not the expert to say who has the major responsibility for that almost incredibly high debt, but I think that every single person, every single Greek person living in having activity in Greece is responsible for that.
Yes.
Now, maybe politicians may be more responsible than citizens, but I cannot exclude citizens from that situation.
Well, you know, we worry about the United States. It has its issues up and down. We have a tremendous debt here. We have politicians that like to spend money, sometimes wisely, sometimes not so wisely. But I think your points are well taken, and that any kind of substantial financial crisis can't just be ignored, and it affects every part of the country, every sort of quality of life. Everything you do is just impacted by this. The issues with banks. I know it was a very difficult time. Are things getting a little better now? Is that your impression, or what do you think?
My feeling is, and I'm speaking, I have to emphasize again that I'm not an expert on the issue, but my feeling is that things seem to be slightly more stable, at least from political standpoint.
Yes.
So I think that this will be good, although the long-term effects of this crisis cannot be evaluated at this point, because I see that many of my graduates from the medical school have to leave the country, have to move abroad for practicing medicine, for taking their residency, their training there.
Yes.
And this is a significant hemorrhage for the country. It's a brain drain for the country.
Sure.
So this is another potential issue that we may face within the next few decades. And I think this is the second lesson that needs to be learned from that financial crisis.
Yes. It's a very complicated kind of story, and we would hope, we have all our issues here in the U.S., things go up, things go down. We can hope that we can at least avoid some of the difficulties that the Greek people found themselves in. Now, maybe we could talk about something, let's see, I won't say, maybe somewhat less complicated than Greek politics, and that's the human brain. I mean, it's that little joke here. So, Kostas, you're a functional neurosurgeon, and so there are lots of things that are really cutting-edge medical issues you deal with in your daily work. And you mentioned epilepsy, which is a pretty common kind of problem. And epilepsy afflicts lots of people. Generally, it's managed, I think, with medication, but not always. And maybe I can throw you a softball. Okay, when is it that you as a neurosurgeon get involved?
Let me just give you an idea about how common epilepsy is. It generally affects approximately 1% of the general population. which practically means that for the state of Georgia, for example, we're talking about 150,000 people, pretty significant.
Big number.
Pretty significant
yes.
number. And the other problem is that epilepsy is a disease with a significant social stigma, and this is something that we cannot deny, although we have made significant progress in that issue. There is still some kind of a very, how can I say that, a very heavy social load. On top of that, epilepsy is a health problem with significant socioeconomic ramifications, talking about socioeconomics again, as you see. These patients, in the vast majority of cases, they cannot work, so they have to just have a special kind of program, and this makes the disease very unique in its management. So we're talking about 1% of the general population with specific conditions. As you said, the vast majority of these patients are treated with medications, but we know that approximately 20 to 40% of these patients will develop a situation which is called medically intractable epilepsy, which means that no matter what kind of medication somebody is on, and no matter how meticulous he is in following that medical treatment, the seizures cannot be controlled by medications. So 30% of 150,000 people, you do the math, and you see that there's a pretty significant number of patients that will develop an epilepsy which is resistant to any kind of medication. And that's where surgery comes to assist. That's where surgery comes to help these patients. Now, all these patients that develop medically refractory epilepsy are good surgical candidates? The answer is no. Approximately 40 to 50% of these patients may be good surgical candidates, may undergo evaluation for some type of surgical procedure. And I think I'll have the chance to just go through these procedures because there are several different procedures, which means that none of them cures epilepsy by itself, but you need to individualize treatment in the vast majority of cases.
And so just talking about that, all right, so we have a patient that is having intractable seizures. Our very skilled neurologist is seeing the patient, doing whatever they can come up with, and it's a very debilitating process, isn't it? So you mentioned the psychological ramifications, all the limitations on driving, swimming, taking baths, water, just the embarrassment that occurs, the secondary impacts, all sorts of negative events occur with uncontrolled epilepsy. So, okay, the neurologist would send the patient to you, and then what would happen at that point?
Actually, the neurologist is the first one who's dealing with this problem with medically intractable epilepsy, and then the patient is referred to a specialized center in the vast majority of cases, and there is a team. It's a team approach to these patients. It's not a solo practitioner's approach. It's not only the neurosurgeon, the epilepsy surgeon. It's a team of people which includes but is not limited to a specialized radiologist, a neuroradiologist,
yes,
who can read all these fancy and really advanced imaging studies that the patient undergoes. There is a specialized neurologist which is called epileptologist.
yes.
There is a specialized epilepsy surgeon, a neurosurgeon with special training in epilepsy surgery, neuropsychologists, and also part of the team are other physicians, other specialty physicians that deal with the pathological examination of the surgical specimen, specialized neuropathologists, and so on. So it's a multifactorial approach, as you can understand, and I think that people need to realize that it's not a simple surgical procedure. In other words, we don't go from the neurologist's office to the operating theater. It's a long process, and it's a really complicated process sometimes in some cases, but I think that at the end the outcome is, in the majority of cases, quite good. It's one of the few fields in medicine, and actually most probably is the only one in neurosurgery, that we do have really strong evidence. When I say strong, I mean from statistical standpoint, strong evidence that surgical treatment is superior in any aspect to any kind of medical treatment. There was actually a double-blinded study which was performed in Canada and showed exactly that the surgical management provided not only better seizure outcome to the patients who underwent surgery, but also better quality of life.
Yes. Now, so there are all kinds of different maneuvers that might be undertaken. I mean, which is quite a complicated story there. But maybe you can discuss disconnection for the seizure focus. I mean, how would you go about that? How would you just get to the point? I mean, so what are some strategies to, presumably what's happening, these aberrant cells are firing, and then when the aberrant cells fire, then it stimulates the whole brain, and it goes to the motor strip or wherever it goes, and it causes a period of abnormal neurological status. So we get all kinds of focal motor issues, things happen. So what are we going to do about that where those bad brain cells are?
You outlined actually the whole process quite nicely. We start exactly from locating where that seizure focus is, where that abnormal electrical activity of the brain occurs. So as soon as we define that area, and there are several different methodologies to do so, then we can either resect that area, we can remove surgically that part of the brain which generates that epileptiform activity, or we can disconnect it surgically from the adjacent brain parenchyma, from the rest of the brain, which is apparently normal. These were the only two surgical strategies, the only two surgical methodologies that we were available till the last decade or so. Now, the last few years we do have a third treatment option, which is the neuromodulation. In other words, we can intervene surgically, and we can, without resecting, without disconnecting, we can modify the electrical behavior or the neurochemical and electrical behavior of certain areas, and that affects the seizure outcome. That makes seizure abolition possible.
So yes, and so there are different ways you do this, and it's a rather complicated story. Now, and I'll just throw you some pitches here. But the vagus nerve is sometimes stimulated. At least people have done that, and maybe you could. Let's see, the vagus nerve, it runs a little along like that, and I think it means wandering, does it not? So the nerve wanders along, and different people have tried stimulating that. And do you have any comments about that? How
That's
well
correct.
That
this is the one type of that neuromodulative procedures that I was talking about. This is the most common one. And actually this is the target, the anatomical target there is at the periphery. It's not in the brain.
Yes.
And they found almost accidentally that there was some kind of effect on seizure frequency and seizure severity by electrically stimulating the vagus nerve. In the vast majority of cases, we do that on the left side, and this is related to the organs that are innervated by the vagus nerve. And we can do that, and we can accomplish a decrease in seizure frequency and severity, as I said. It's not one of the procedures that will provide a seizure-free outcome as resective surgical procedures or other disconnecting surgical procedures, but this is one typical and quite popular modality of neuromodulation. Now, there are several other modalities. The anatomical target may be deep in the brain.
Yes.
And in these cases, we talk about deep brain stimulation, electrical
stimulation. That's a good turn of
stimulation.
phrase, deep brain stimulation. I like that. That's a
Exactly,
good turn of
because
phrase.
we are deep in the white matter of the brain.
Yes.
There are cases that we stimulate electrically the cortical surface of the brain, and we talk about cortical stimulation. And then there are situations and cases that is necessary to stimulate both deep in the white matter and superficially.
Yes.
And in those cases, we stimulate with different electrodes both places.
Yes.
There are also two types of neuromodulation devices, two types of stimulators. There are devices that can detect some kind of abnormal electrical activity, and they can deliver an electrical stimulus only in these cases that there is a detection of abnormality. And there are other systems that can deliver in frequent periods of time some kind of electrical stimulation, like a pacemaker for the brain.
Yes, yes. So there are all kinds of advances that are taking place in your particular field of endeavor in functional neurosurgery. Now, often, I think you may have occasion to operate with the patient being awake. Is that not an uncommon? You do that on occasion? And any comments about that?
That's correct. Actually, in a pretty significant percentage of functional neurosurgical procedures,
Yes.
the patient needs to be awake and needs to be cooperative, and this is in order to be able to identify areas that may be at risk, functional
Yes.
areas of the
Yes.
brain. We usually call them eloquent cortical areas.
Yes.
And these are mostly related with speech production or with movement or sensation. And we do that for an accurate intraoperative cortical mapping.
Yes.
Now, there are several different ways and advantages and disadvantages for performing different techniques, but I think that it's what needs to be passed away is that the most important thing is to just be accurate in what you resect or what you disconnect in the brain. But at the same time, you need to be as aggressive as you can as a neurosurgeon.
Yes.
So I think that cortical mapping and subcortical mapping, white matter mapping,
Yes.
can provide that opportunity to a neurosurgeon to be accurate, but
Yes.
at the same time
Yes.
aggressive and safe.
Yes. Now, for some people in the TV audience that are out there, I say hello to you, but 2 or 3 of you that are out there. But when you do this, it's really kind of a daunting thing, isn't it, for a patient to undergo something like this? Or do you talk to them beforehand? You're going to have brain surgery, and you're going to be awake while someone operates on your brain.
It sounds.
Does that sound a little
It sounds
spooky to
scary.
people?
It sounds scary. And when I started actually my training, my fellowship in epilepsy surgery, I was expecting significant problems with the patient, but the matter of fact is that the vast majority of them tolerate the procedure quite well. Of course, it requires a significant amount of time. Everything needs to be
Yes.
explained to these patients, and they need to be aware that they are going to be awake during the procedure. They'll be able to listen to the
Yes.
conversations, all the sounds in
Yes,
the operating
yes.
room. But on the other hand, there is no pain experience.
Yes.
So it's absolutely pain-free, and they
Yes.
can, I think that most of them can go through the procedure with no significant problems.
Yes, yes. Well, that's I think something that a layperson is quite a mountain to climb to accept that. Now, you mentioned you do functional neurosurgery, so all kinds of things sort of fall in that bailiwick besides doing epilepsy surgery. I mean, sometimes, maybe you can discuss this, there's a discussion out there about doing different kinds of intervention for abject depression and going in and doing a deep brain stimulation for that. I mean, that's an issue that's one of controversy, I think. Could you discuss that a little bit? A person
Sure,
that's tremendously depressed, and is there something we can do to that person's brain to make life worth living?
You know, psychosurgery as a neurosurgical field has a really sinful past,
Yes.
particularly, especially in this country. But I think that neuromodulation provides us the opportunity to intervene in a reversible manner.
Yes.
And I think that we can greatly affect several psychiatric disorders, such as depression that you mentioned, or personality disorders, obsessive compulsive
Yes.
difficulties, addiction difficulties, all kind of psychiatric
yes.
problems. Now, we are not quite successful with all of those diseases, but I think that it's a very promising treatment modality
Yes.
for dealing with, again, with medically refractory psychiatric disorders.
Yes.
In other words, when we talk about intervening in surgically in a depression
Right.
case,
Yes.
we know from our psychiatric colleags that this patient is not responding to proper medication.
Yes. Yes. So one of the issues out there is actually, as neurosurgeons, we have to be very aware of ethical issues involved in any intervention on the brain. And you've mentioned some of the bad things that happened in the past with frontal lobotomies. So we have all kinds of terrible things that happen. And no one is going to arbitrarily do something without very, very severe restrictions. But that's, I think, something, there's at least some papers out there. Some people do that on some occasions with benefit. Now, another part of functional neurosurgery that is quite useful these days is for Parkinsonian problems. Do you have any comments about that, or how is that working?
I think that this is an aspect of functional neurosurgery that really gave life to functional neurosurgery during the last 2 decades.
Yes.
Actually, most of the patients with appendicular symptoms with tremor
Yes.
Respond quite well to deep brain stimulation.
Yes.
And it's not only Parkinson, but several other movement disorders,
Yes.
such as severe forms of dystonia
Yes.
and Tourette's syndrome,
Yes.
and different kind of problems. So I think that we are quite successful in that aspect of neurosurgery. And
Yes.
it's, again, one of the most promising fields of functional neurosurgery.
Yes, yes. Well, so there are many people that have Parkinsonian problems. They go through a very long, trial with different kinds of medications. That's sort of getting near the end of their treatment modality, is it not? To sort of get to that point, how soon would you intervene in a Parkinsonian patient?
You know better than I do that it's really difficult to generalize for
Yeah, of course, yes.
patients. But I would say, as a general rule, that it would be better to be evaluated at least
Yes.
by a functional neurosurgeon, a patient with Parkinson's
Yes.
disease, and see if would be a good surgical candidate, a potential surgical candidate. And I think that in those cases that the patient qualifies for surgical intervention, the sooner the intervention will be offered, the better the outcome will be.
Yes. Well, let's discuss that a little bit. So what kind of, if we go through an evaluation for Parkinsonian problems, many people have Parkinsonian issues, and it's a substantial impediment. But all the issues are out there. You go through different kinds of trials of this and that, and a big journey to get to this point of your treatment modalities when someone does something. But what exactly would you do? How would you treat? I mean, I'll just throw whatever particular patient you want to discuss, or whatever kind of problem you would discuss. How are you going to go about? You're going right into the.
This is another
yes.
procedure that is performed in the vast majority of cases with the patient awake. We
Yes.
want the patient to be cooperative in
Yes.
the OR. And it's actually a surgical procedure that starts before even getting the patient to the OR. All the surgical planning, the identification of the target for the stimulation
Yes.
is or are identified preoperatively by the physician, by the surgeon, and his co-workers, and this is in close collaboration with specialized neurologists.
Yes.
And then the procedure, as I said, is performed under local anesthesia. And what we usually do, we just implant, we insert a tiny electrode
Yes.
deep into the brain, into
Yes.
the areas of the basal ganglia of
Now
the subthalamic
that's
nucleus.
very deep in the brain.
That's true.
That's way, way down.
That's
very deep in the
true,
brain. Yes.
but we do have the technology, and this is actually available with all these neuronavigational systems that we've got, and also electrophysiological
yes.
systems
Yes.
that gives us the opportunity to have quite high sub-millimetric accuracy.
Yes.
And we also have electrophysiological monitoring with microelectrode recordings during the procedure that can give us a verification of the target. And the outcome is quite good in
Yes.
percentages that are higher than 70 to 80%.
Yes. Yes.
So it's quite good for a really severe neurological disease.
Yes. Now, one of the areas of controversy that's appeared in this is using stem cells, putting stem cells in. I mean, different. So there's an area of, I'll politely say, of controversy. But would you discuss that then? I mean, people sometimes have done that with mixed results, I would say.
There are series published in good medical journals with very enthusiastic results, but I think that I'm not experienced in that part of, in that field of neurosurgery, but I think that we'll be able to do within the next few years some really significant achievements coming down the pike through that.
Yes. Well, okay. I'll throw you the last question here, Kostas. Where do you think functional neurosurgery is going? I mean, what progress is going to occur in the next decade, do you think?
You know, if you were asking the same question 10 years ago, I would have a very pessimistic response to that. But neuromodulation gave us the opportunity to be very optimistic And I think that we'll be able to see more and more neurosurgical interventions in the form of neuromodulative procedures in a wide spectrum of neurological diseases, not only psychiatric diseases, but also eating problems, eating difficulties, and other problems such as dementias will be, I think, surgically amenable in the near future.
Well, okay. Well, great. Kostas, it's been nice talking to you
Thank you
tonight.
very much. Thanks for having me.
Good to see you. We'll talk some more. Thank you.
Okay, thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.